And I think this meeting is of particular importance for us because it's completely organized by our own young community. And today we will talk about ECG abnormalities and related conditions that can be observed during COVID-19 disease. And we have a great faculty, so let me introduce them to you. I will try to moderate the session with my friends, Dr. Kira Lieblich from Canada and Professor Gareth Se from China. And in the first presentation, Dr. Sharon Lee will talk about sudden cardiac death and arrhythmogenesis that can be observed during the disease. And in the second presentation, Dr. Gabriela from Brazil will tell us about ischemic changes that can be observed during the disease. So I think we have lots to learn from them because I know they are doing considerable amount of research about their topic. And before leaving the stage to them, a final remark is that if you have any questions or comments to make, just write down the chat box or click raising hand button. So at the end of the presentation, I can unmute you and hear your comments. So Sharon, the stage is yours.
Thank you. Let me share my slides. So greetings, everyone. My name is Sharon Lee, and today I'm here to give a brief presentation on sudden cardiac death and arrhythmia in COVID-19. So today I'll be discussing this topic in 3 areas. First of all, the increased risk of sudden cardiac death and arrhythmia amongst COVID-19 patients. And secondly, the proarrhythmic risk in the pharmacotherapy that's used for treatment. And finally, the increased risk of sudden cardiac risk amongst both survivors of COVID-19 as well as the general public amongst the pandemic. So to introduce the topic, we should know that myocardial involvement was actually found in 20 to 30% of COVID patients who require hospitalization over COVID-19. And the presence of arrhythmia marks disease severity, where a higher prevalence was found amongst patients who require intensive care, whereas a lower prevalence was found among stable patients. It is also a prognostic marker where it is associated with higher morbidity and mortality. So these 2 diagrams are from a meta-analysis consisting of 1,845 patients comparing between COVID-19 survivors and non-survivors. So the top panel demonstrates that the development of arrhythmia is a predictor of mortality, and the bottom panel shows that the development of acute myocardial injury is also a predictor of mortality, which demonstrates the prognostic implications of the presence of myocardial injury amongst COVID-19 patients. In addition, we should also be aware of the arrhythmic potential in the pharmacotherapy used for treatment, most notably hydroxychloroquine and azithromycin. And therefore, we should be aware of the potential myocardial and arrhythmic sequelae amongst COVID-19 survivors, and awareness for long-term cardiac surveillance and treatment should be raised. This is a diagram describing the possible pathways involved in myocardial injuries in COVID-19 patients. And the increased risk of arrhythmia and sudden cardiac death is mainly due to the presence of fibrosis, which interferes with the conduction pathways, predisposing patients with atrial fibrillation and ventricular tachyarrhythmias. This is particularly important in those of subclinical COVID-19 course where they may not have extensive workup performed. And therefore, surveillance is important for early identification of clinical cardiac disease, thus allowing for early intervention to improve these patients' prognosis. Now, the 2 diagrams on the left from 2 studies, a single-center study from the United States, as well as a multi-center study from Germany. Now, the 2 diagrams demonstrates that there is a similar distribution of the types of arrhythmia present in COVID-19 patients across different centers and countries, where atrial fibrillation is the most common. And the panel on the right shows that the presence of arrhythmia is associated with disease severity as demonstrated by the intensive care unit admissions, and both the presence of atrial fibrillation, and ventricular tachycardia are associated with a more severe disease course. In this slide, I'll be summarizing some of the major mechanisms underlying the generation of arrhythmia amongst COVID-19 patients. As shown on the diagram, many pathways are involved. For example, acute myocardial injury is a major underlying mechanism, as demonstrated by the association between elevated troponin with the generation of ventricular arrhythmia found amongst these patients. In addition, electrolyte disturbance may also be a possible mechanism, most notably hypokalemia and hypomagnesemia. Under a state of systemic inflammation in severe COVID-19 disease, the presence of pro-inflammatory cytokines may induce remodeling in the heart, which predisposes patients of an increased risk of arrhythmia generation. In addition, there is also reports of autonomic imbalance, where there is sympathetic hyperactivation under the state of inflammation, as well as vagal attenuation due to vagal nerve damage that is reported in some COVID-19 patients. And under prolonged fever, it may unmask underlying channelopathy in patients, for example, Brugada syndrome. And other mechanisms such as cytokine storm may also be involved, and the risk of arrhythmia in the drug therapy use would be further explored in later slides. Now let's discuss the possible markers for increased sudden cardiac death risk amongst COVID-19 patients. These markers can be divided into clinical, electrocardiographic, and laboratory. The clinical markers are mainly related to risk factors of cardiovascular diseases, as well as markers of severe COVID-19 disease, such as history of coronary heart disease, the requirement for vasopressors or mechanical ventilation, old age, or higher BMI. This diagram is a decision tree using only clinical factors for the risk stratification of sudden cardiac death risk amongst COVID-19 patients. It is from a single center study from Israel, consisting of 390 patients. Although because it is a preliminary study that they don't have the analysis of the accuracy and the predictive value of the decision tree, it demonstrates that the use of clinical factors alone can be used as a simple risk stratification tool that can be easily used in a clinical setting to evaluate the arrhythmia risk in this patient cohort. In terms of the electrocardiographic risk factors, many of the markers are related to abnormalities in ventricular repolarization, such as QTc prolongation or TPT at intervals, as well as the ratio between TPTN and QT interval. As demonstrated by the two diagrams, there is a positive association between these markers of abnormalities in ventricular repolarization and C-reactive protein, which is an inflammatory marker, which suggests that these abnormalities in ventricular repolarization is likely due to an underlying inflammatory cause. Other markers include QRS widening, PR depression, as well as pre-existing arrhythmias such as bundle branch blocks and ventricular ectopics. In terms of the laboratory markers, these are mainly markers of myocardial injury and inflammation. And demonstrated on these diagrams, these markers can also be incorporated into a holistic score, perhaps in the future, for risk stratification of arrhythmic risk in COVID patients. Now let's shift gears to discuss the arrhythmic risk amongst the pharmacotherapy that's used to treat for COVID-19 patients. So most notably, hydroxychloroquine has a known arrhythmic risk, and based on a pharmacovigilance analysis of the FDA adverse event reporting system, QT prolongation was found up to 10% of the patients that use hydroxychloroquine for the treatment of COVID-19. Furthermore, the presence of drug-drug interaction will further increase the risk of arrhythmia, whether or not it is drug-drug interaction between drugs used to treat for COVID-19 or the interactions with the drugs that patients have already been prescribed for other reasons. This is because of the different mechanisms in that hydroxychloroquine and azithromycin has been reported to cause arrhythmia. For example, basic studies have shown that whilst torsades pointes is usually due to early after depolarization, azithromycin rarely causes so. And instead, it targets the HERG channel, which shares the same mechanism of arrhythmia generation as long QT syndrome. On the other hand, hydroxychloroquine may increase action potential dispersion. And by involving different pathways in the generation of arrhythmia, they may potentiate the arrhythmic risk between each other, thus posing the patient in further risk of sudden cardiac death. Whilst in earlier studies, there is fewer reports of the presence of arrhythmia in patients. In a recent meta-analysis, it has been reported that around 14% of patients that have been infected with COVID actually develop drug-induced long QT syndrome. Based on these findings, when we prescribe drugs with arrhythmic risk for the treatment of COVID-19, there are several things that we should keep in consideration. First of all, the arrhythmic risks in the patients themselves, such as pre-existing QT prolongation, known long QT syndrome, as well as a history of torsades de pointes. In addition, we should avoid prescribing these drugs in high dose, as the arrhythmic risk was reported to be dose dependent. Furthermore, we should also aim to correct for any underlying electrolyte disturbances, in particular hypokalemia and hypomagnesemia. Other QT prolonging agents should also be avoided. And amongst these patients, we should have a close monitoring of their electrocardiogram. However, it should be noted that polymorphic ventricular tachycardia can occur in the absence of QT prolongation under the use of azithromycin. In addition, QT prolongation was reported to remain stable after the drug prescriptions. So on the other hand, multiple daily ECGs are not indicated. So this is a diagram that illustrates the Canadian Cardiovascular Society's guideline in terms of the prescription of pharmacotherapy that has arrhythmic risk for COVID-19 patients. And the main point of this guideline is that we should identify for risk factors of ventricular tachyarrhythmia in patients and to minimize the additional risk by electrolyte correction and to avoid a further increase in their arrhythmia risk. So amongst low-risk patients, we can simply initiate the antimicrobial. However, on the other hand, amongst high-risk patients, we must keep a close monitor and discontinue the drug if there is significant QT prolongation. Now, these two diagrams are from a single-centered study in Lithuania to examine the mitigation of arrhythmia risk in hydroxychloroquine and azithromycin use through the use of a management plan. The diagram on the left illustrates the corrected QT interval over the course of treatment, whereas the panel on the right is the change in corrected QT interval over the course of treatment. And these two diagrams demonstrate that the QT interval remains stable with no episodes of ventricular tachyarrhythmia under the implementation of this center's cardiac arrhythmia risk management plan for all hydroxychloroquine or azithromycin users for COVID-19. And their management plan is as follows. First of all, they would discontinue all other QT prolonging drugs that's been prescribed to the patient. And these patients would also have daily electrocardiographic monitoring with the calculation of their corrected QT interval. And if the patient is hypokalemic or hypomagnesemic, they would have their potassium and magnesium replaced. If the corrected QT interval reaches 480 milliseconds, and both electrolytes would be replaced to reach the maximum normal value. And if the corrected QT interval reaches between 480 to 500 milliseconds, then the risk benefit of the use of these drugs would be reviewed. And finally, unless the patient is already in intensive care unit where continuous electrocardiographic monitoring would be performed, the drug would be discontinued if the corrected QT interval is greater than 500 milliseconds. And the findings from the study demonstrates that the proarrhythmic effects of these drugs can be well managed through effective preparation and standard protocols. Next, let's discuss the risk of sudden cardiac death among survivors of COVID-19. Although there's yet to be studies reporting the long-term surveillance of COVID-19 patients, studies on post-myocarditis arrhythmia may be relevant for our discussion. And it has been found that there is an increased risk for atrial and ventricular arrhythmia under a post-myocarditis, regardless of left ventricular ejection fraction. In addition, there is also a high prevalence of sustained tachyarrhythmia amongst hospitalized patients. Whilst ventricular tachycardia predominantly affects the in-hospital adverse outcomes, such as mortality, those with persistent atrial fibrillation may have an increased risk of sudden cardiac death in the future, given the increased risk of ventricular tachycardia from residual conduction abnormalities, which will be further discussed in the next slide. This diagram is from a multi-center study in Italy on predictors of new onset arrhythmia in COVID-19 patients. And as demonstrated on the diagram, there is an interrelationship between atrial fibrillation and ventricular tachycardia, where they are predictors of each other. This demonstrates that the persistence of atrial fibrillation may increase the risks of ventricular tachycardia amongst these patients. Aside from looking at the risk of sudden cardiac death amongst the general survivor cohort, we should also look at specific survivor subgroups, such as athletes, where they're at a higher risk of sudden cardiac death given their occupational risk. And these are suggestions recommended by the American College of Cardiology's Sports and Exercise Cardiology section, and it is based on guidelines on suspected myocarditis amongst athletes written by the American Heart Association. So before returning to sports, these athletes should have undergone extensive workup to exclude any clinically relevant arrhythmia. And they should only resume training or competition after a normalized ventricular systolic function, as well as serum markers of myocardial injury, heart failure, and inflammation. Besides from the risk of sudden cardiac death among survivors of COVID, we should also look at how public health measures would affect the sudden cardiac death risk amongst the general public. Now, this is a diagram from a review from our team on the hypothesized increased risk of sudden cardiac death due to the use of face masks under exercise. The use of face masks is mandated in many countries around the world, and exercise is beneficial for our cardiopulmonary health. However, the use of face masks during exercise may increase arrhythmic risk. It is due to a hypothesized sympathetic stimulation and enhanced chemoreflex hypoxia, which increases myocardial oxygen demand, which may aggravate arrhythmia in those of underlying pathology. In terms of the initiation of arrhythmia, it is possibly due to triggered activity or the presence of ectopic foci under hypoxia, and the persistence of arrhythmia may be due to re-entry foci such as sites of fibrosis or refractoriness. And under the state of hypoxia induced by the use of face masks, it may increase action potential, dispersion, and oxidative stress, which may cause conduction abnormalities and heterogeneous conduction. While these mechanisms may be deemed insignificant amongst healthy individuals, it may pose a significant threat towards those with underlying pathology or channelopathies, such as Brugada syndrome. And finally, I would like to discuss the effects of the pandemic on out-of-hospital arrest incidents and survival. These two diagrams are from a study on 4 provinces in Italy in the 2 months since the outbreak of COVID-19. The panel on the top illustrates the cumulative incidence of out-of-hospital arrests, whilst the panel at the bottom illustrates the difference in the incidence of out-of-hospital arrests comparing with 2019. These two panels demonstrate that there is a significant increase in out-of-hospital arrests during the pandemic. In terms of reasons directly related to COVID, it may be due to an increased risk of lethal arrhythmias, possibly secondary to a respiratory distress syndrome and causing hypoxia. It may also be due to a severe COVID-19 cases that have been missed and do not reach the hospital in time, resulting in an underreporting of COVID-related out-of-hospital arrests. And in terms of indirectly related reasons, it may be due to the increased psychological distress from both the public health measures of lockdown and the pandemic itself. This is a diagram from a population-based observational study in Paris on non-traumatic out-of-hospital arrests, where the proportion of patients admitted alive at the hospital after an out-of-hospital arrest has been illustrated. And as portrayed on the diagram, the proportion of survivors dropped significantly after the Paris lockdown. This may be due to several reasons. First of all, the overwhelmed medical system unable to treat these patients in time. And second, in addition, it may also be contributed by the reluctance to perform CPR in arrested patients under the threat of the pandemic. And if the patients are already COVID infected, they may already be hypoxemic or have, to some extent, cardiac injury, which impairs their prognosis further. So based on our discussion so far, there are several take-home messages. First of all, ventricular tachyarrhythmia is an uncommon but important complication in COVID-19. Secondly, proarrhythmic antimicrobial use should be evaluated with care and closely monitored. And thirdly, COVID-19 survivors have an elevated risk of sudden cardiac death and arrhythmia, thus require long-term surveillance. And finally, further research is needed to develop a protocol for the surveillance of arrhythmic risk amongst COVID-19 patients. So thank you very much.
Thank you very much for this excellent presentation. And I think it's better if you take questions at the end of the second presentation, so you can discuss in more detail. So, Gabby, please tell us more about what ischemic changes can we expect during the disease. So, stage is yours.
Hi, everyone. I'm Gabriela. I'm from Federal University of Minas Gerais, Brazil, and I'm going to speak a little bit about the ischemic ECG abnormalities. I have no disclosures for this presentation. So the report is from Johns Hopkins. I got it 2 days ago, and as you all know and can see, we have more than 100 million cases and more than 2 billion global deaths all over the world. So it's really a disease, and it has that we have to study and improve our knowledge. Going to the cardiovascular system, as Sharon mentioned a little bit, and the COVID virus attacks especially the lungs, and most of patients have pulmonary respiratory syndromes, but we also have some changes in the biomarkers, especially the cardiac ones, as troponin and the NT-proBNP. And we know it that the virus can cause myocarditis, increases thrombosis and arrhythmias, as have been shown. And patients with cardiac clinical conditions have more risk of and a worse prognosis in the COVID-19. So one of the mechanisms of the cardiac involvement is the attachment of the virus in the ACE converting receptor, and that can lead to the direct cardiac injury. So we have called, it was publication and known that as acute COVID-19 cardiovascular syndrome, that we can have clinical involvement that can be really variable. We can have acute coronary syndrome with obstruction of the coronary artery. We can have acute myocardial injury without obstruction of the coronary arteries, arrhythmias, heart failure, pericardial effusion, and thromboembolic complications. And the mechanism of the injury is multifactorial and they can overlap. But we know that the systemic inflammatory response, the direct myocardial cell injury, and can cause myocarditis. And we know that the myocardial infection can be due a type 1 myocardial infection as plaque rupture with the obstruction of the artery, but it can also be a mismatch between the oxygen supply and demand, and also microangiopathy due to the cytokine storm. And the arrhythmias Sharon has mentioned. So the electrocardiogram plays a special role in this disease because it's an easy to perform exam and it's a screening for the cardiac involvement and the baseline risk. So at the admission of the patient in the hospital, it must be performed so we can see the baseline risk of the patient if the patient has already some cardiac involvement. And we can see the Cornell University published this paper with about 150 patients, and they show that some electrocardiographic abnormalities are associated with higher mortality, despite of the age, sex, and clinical conditions, as atrial premature contractions, intraventricular block, and T-wave inversion and non-specific repolarization that can show some of left ventricular ischemia, and also the development of a new right bundle branch block can be related with pulmonary embolism, and they are all associated with higher mortality. Another paper also shown that an abnormal ECG at the admission of a COVID patient is associated with major event. And I want to highlight especially these primary STT segmenting alterations. We can see that 13% of the patient had major events with a p-value statistical significance. And this is an example of an ECG of a patient of this study showing a left ventricular hypertrophy and the ST changes. Another case report published, it was a woman, 63 years old, that it was admitted in an ER with dyspnea. It didn't refer flu-like symptoms at the moment. And this was the ECG. So you can all see that there is a diffuse ST segment elevation with an ST depression of AVR that is typical from pericarditis, but the patient had an echo with wall motion abnormality in a specific region of the heart. So she underwent coronary angiographic that was normal, and the MRR confirmed myocarditis. And this is the X-ray of the patient, normal. This other patient from Brazil, it was admitted without any respiratory symptoms, only chest pain, and this ECG, that's all you can diagnose as ischemia in the inferior wall. And 1 day later, started with a fever, and this is the CT. They publicated, a hospital from New York, published in the New England case series of 19 patients with COVID-19 with ST segment elevation. And of these 18 patients, 8 had myocardial infarction with obstructive coronary angiographic, and 10 was non-coronary myocardial injury. I want to highlight that the clinical presentation is very variable, and we can rely on one symptom to define if it's ischemic or non-ischemic. And also the electrocardiographic findings are also variable. You can see that in the non-coronary myocardial injury, we have focal elevations. 60% have focal elevations. So it's not always a typical ECG of pericarditis with the diffuse ST elevation. And also the echo findings can be alterated in both cases, as you can see. And so with all of this, Mahmoud and his colleagues published in JACC last year a guideline, a proposal of a guideline for the management of an ST elevation on the ECG. And they put it that if the patient may have COVID, it's a positive or probable, you have to see the symptoms, the ECG, and consider POCOs to confirm the wall motion abnormality. But we have to question a little bit this, because as I say, you may have atypical symptoms. The ECG may be the same, may have focal ECT elevation, and you can have wall motion abnormality even only in myocardial injury. So it's really challenging to define if it's really a STEMI or only an acute myocardial injury, and we don't have data that we can rely to define that. We have to see individual cases, and the decisions should be considered in a emergency department joint and case by case. There's a registry that US is performing with STEMI patients with COVID. It's still ongoing. Maybe after this registry, we can have more information. And during the hospitalization, the ECG is really important because it can diagnose cardiac complications, and as also Sharon highlighted, the complications of some medications with the prolongation of the QTc interval. So the same paper, here we can see that in the 7 days hospitalization, patients that have abnormal ECG have also worse prognosis, have more major events. And that can be explained for several reasons, because patient may be in the ICU with pulmonary distress, renal injury, electrolytic abnormalities, but the ECG is a prognostic marker of the disease. So here we have a new onset atrial fibrillation with ST depression and T wave inversions. And this patient have had a worse prognosis in the follow-up. Another thing that I'd like to highlight is the ECG modifications. This patient he's 23 years old. He was admitted with respiratory symptoms, as you can see in the X-ray here. The ECG was normal. And 24 years later, in the discharge exam, the X-ray was good, the oxygen, the ratio was better, and he developed T-wave inversion. Echo was normal, but how should we follow this patient? We don't know yet. And other fact is this: another patient, 60 years old, ECG normal at the admission with pulmonary involvement, important pulmonary involvement. In the discharge ECG, we can see ST elevation and ST depression in AVR. This patient have important pericardial effusion, a pericarditis. So we can see that the cardiac involvement can appear only in a late stage of the disease and do not have a relationship, a clear relationship with the pulmonary involvement. So both patients have shown an improve of the respiratory syndromes, but they have changed the ECG, and this one had a complication, a pericardial effusion. And these were the changes between the admission and the pre-discharge ECG. And the one that showed statistical significance, it was the Cornell voltage, showing maybe that pre-discharge, a lot of patients can have some of pericardial effusion, and we should be aware of this complication. And finally, the outpatient follow-up, the long term. As Sharon mentioned, this is from American Journal. They recommend for athletes, they should all perform an ECG and troponin and an echo to be permitted to return to play, to perform physical activity. And they can also, despite of the findings here and the symptoms, go in a further investigation with MRR and etc. This is another challenge with the ECG screening post-COVID, because here in this figure A, we can see the ECT elevation, early repolarization, that's normal, that we can find a lot of athletes. And in B, we have the same pattern, and it is association with pericarditis, with pericardial effusion. In a paper published this year that the former cardiac MIR in patients post-COVID, they found that 30% had late gallium enhancement, with the location more in the mid-myocardium or the subepicardium, but they have a scattered distribution, as is shown by the arrows here. And so we still have a lot to learn about these outcomes and long-term follow-up. We have to study to see the surveillance and the guidelines in patients post-COVID. A little bit of spoiler here. Our center is the ECG center reader in a research of the World Heart Federation that are performing ECG in patients with COVID-19 all over the world. And we have already reported more than 1,000 ECGs. And I want only to highlight that that our most frequent abnormality, it was the code 8 of Minnesota, that is arrhythmia. Probably the most common is sinus tachycardia. And some take-home message that the COVID-19 in the heart is multifactor, with a lot of overlapping between the mechanism of injury. Clinical presentation is variable and do not related always with the respiratory symptom severity, can be later. They can have a late presentation. We should always perform an ECG. And the follow-up of these patients, we still have a lot to learn. In athletes, we have to be more surveillance, but we still have a lot to learn, because we don't know if these scars in the MRR will become ventricular arrhythmias, will increase the risk of sudden deaths. I want to thank you all, and I'm available for any doubt.
So thank you, Gabriela, and it was an excellent and comprehensive presentation. So we have about 15 minutes to discuss and for questions. I think I saw a couple of them, one from Professor Baranchuk to Sharon. And Sharon, do you think that this proarrhythmic effect seen in COVID-19 is specific of COVID, or is it the same for any other infectious severe disease? I mean, is it something of this virus, or is it that we only know more about this virus rather than influenza or some other virus? So do we have some bias for that?
Well, I think for this question, we certainly need to do more research in this area to have a very definite answer. But from studies that we can see that it seems to be amongst those with severe disease, the myocardial involvement seems to be higher than those for example, influenza. So that may reflect certain sort of predisposition of cardiac effects of this virus. And in addition, with our use of drugs, I think that also plays a big role in terms of the higher cardiac involvement seen in COVID patients.
Okay, thank you. And one question from Dr. Vincentas Vicut is that you mentioned that COVID-19 may cause channelopathy. So is it hypothetic or theory, or get some real clinical data or clinical background?
So there has been a number of case reports reporting on this phenomenon. So it is from the case reports, and we're mainly finding that it is likely the fever that unmasks the underlying channelopathies already present, but rather the presence of this disease simply allows the manifestation of the channelopathies.
Okay, thank you. And I would like to ask Chiara or Gary for their questions and comments.
Thank you so much, both of you. I really enjoyed your presentations. I actually have a question about the long-term sequelae. So I know that in these studies, a lot of the focus is, of course, on older individuals and moderate to severe disease. Do you think that we're missing any, I guess, cardiac damage happening in younger people who it may be masked in, and that we'll see in this population as they age, that we'll have earlier onset of electrophysiological abnormalities, or I guess more severity than we do in our general population?
Yes, Kat, I think we can be missing, because younger patients don't go to hospital unless they have like higher fever or dyspnea. They keep in the house because they don't have clinical conditions associated. And we also see that the cardiac involvement can happen with subclinical COVID. It has been reported. So I think we will be surprised later with some cardiac MRR with scars and ventricular arrhythmias and something like that. But it's still we can say much because we don't know, and that will need of surveillance and bigger studies and to have this information and this confirmation.
Thank you. And then do you see maybe a screening at the population level long-term?
Yes, maybe a screening of the population long-term, and we are conducting a study on ECG in COVID patients, and all patients from our state in Brazil are performing an ECG, and maybe that we can surveillance patients with any ECG abnormality, because we saw that patients, even with non-specific ventricular repolarization, have worse prognosis. So they can't have some scar, they can develop arrhythmias. I think we will need some population screening. Maybe this study can help, and also the registry from the World Heart Federation that is performing more than 5,000 ECGs in COVID patients.
Perfect. And then, so I suppose then that with follow-up, there's of course cost, right, to individuals who don't have healthcare coverage. Do you foresee government intervention based on these studies and to, I guess, cover COVID follow-up in terms of cardiac care?
Yes, I think maybe the government, like we can propose an algorithm for all patients with COVID-19 should perform CG 3 months later, something, because we can't do cardiac MRI in all COVID-19 patients. It's not reasonable. And it's cost a lot. And especially for us that we come from middle and low income countries, we don't have this money, but we have ECG, and we have shown the ECG has a lot of prognostic markers. So we can use the ECG for screening and follow up, and maybe with some ECG abnormalities, go further investigation.
Thank you so much. I'll pass it along to Gary if he has any questions.
Yeah, so
Gary, we missed you. Are you still there? Yeah.
Yeah, definitely here. So this is a question not just to the two speakers, but maybe an open question to you all. So clearly, the problem of ventricular arrhythmias is a big issue, but it's quite difficult to separate out the component causes. So whether it's due to underlying inflammation, whether it's due to some myocardial ischemia, whether it's due to drug-induced Q2 prolongation. So I'm just wondering whether any of you are aware of studies that have done the comparison between patients with and without myocarditis, how much of the arrhythmia is due to inflammation, or how much of the arrhythmias is due to drugs like azithromycin or hydroxychloroquine. I'll be quite interested to know.
Yeah, so far I don't think I'm aware of any studies in this area, but I think that is certainly an area that we can all look into, and if we have the resources, definitely a possible topic that we can do a study on.
It'd be quite interesting if we can pool all of the resources together. We probably have maybe 500 cases in each center. We can do some sort of propensity score matching study where we compare patients with and without myocarditis, controlling for the degree of myocardial damage and other confounding factors. So we might be able to answer that question as well. Depends how keen everyone is. I think it's doable.
So if we have no further questions, I think we can close the session if Rob is okay with that. And I would like to ask all the audience to turn on their camera so we can take a group picture to share it during social media. So please, can you do that? So I would like to thank all speakers, Gabriela and Sharon, for their excellent presentation, and to Chiara and Gary for their excellent contributions. And finally, I would like to thank Rob for all this technical support for this webinar and all the things that we do as International Society of Young Community. So thanks for everyone joining us today, and I hope to see you in the next ISE webinar, I think next month. So thank you.
Thank you.
Thank you.